this presentation, there are a couple different directions I can take this. I thought what ended up happening is I just did a general overview. If you've got any questions about sort of how we, evaluate patients and determine their candidacy for different procedures, please stop me. If you've got any questions about the procedures themselves, just let me know. Otherwise, it's just sort of an overview of like sort of how sleep medicine and sleep surgery specifically has developed and what current practices are right now. So, so just outline, we'll go through some of the objectives, the burden of OSA, and I wanted to look at the burden of OSA both in the United States, which we deal with, and then very briefly in South Africa. Why should we care about OSA, the evolution of sleep medicine surgery, our current practice, what's being dreamed up next, acknowledgements, and then Prof. White sort of is like, one of the things that sparked this is like, does sleep surgery work? Is this a silly thing that we're doing? Like, is there, and then this is actually like a big controversy that is slowly being eroded away by multiple studies, at least in the US. It's something that sleep medicine, sleep surgery used to clash heads quite intensely. And now we're starting to work together a little bit more cohesively. So hopefully by the end of this, understanding importance of treating OSA, historical perspective of sleep surgery, different pharyngeal techniques, and then my favorite, the hypoglossal nerve stimulator. So in the United States, OSA is a pretty significant problem. It's 5 to 30% of the population have moderate to severe OSA, and this is moderate OSA is defined as an AHI or apnea-hypopnea index of 15 to 30, and then above 30 is severe. And this is important because above 15, you start to get cardiovascular sequelae from poor sleep. In the US, CPAP is covered by most health insurance. If you get a home sleep study or a PSG and you're demonstrated to have OSA insurance, because the burden of sequelae is so high, because cardiovascular health is so high, and then honestly, all comes down to commitment. It's so expensive to treat patients with hypertension, with stroke, with heart disease, with AFibs. This is something insurance companies have jumped on to try to treat. And then oral device appliance therapies also covered. And then when patients fail those, the hypoglossal nerve stimulator is also covered. And this is important because these things are very expensive. So how does this fit South Africa? So there was this paper published in 2020 via Thoracics Critical Care in Africa. Nearly 23% of the adult population is moderate to severe OSA in South Africa. But CPAP is very expensive here, much more expensive than it is in the United States because of that insurance burden. The list of those 5,000 are. I couldn't see much evidence of hypoglossal stimulator being done here, although I'm not sure it's done. I don't think you guys do it here at all. Yeah. And then it seems like most of the procedures done here are like tonsillectomies. I think you guys have moved a little bit away from UPP, which is good, as I'll get into. So why do we care about OSA? And it has an incredible burden on life. So when you have somebody who's not sleeping well at night, they have an episode of apnea, they sort of wake themselves up, which results in this fragmentation of sleep. But as they're sort of, falling back asleep, their, muscles, tissue collapse, and you get these episodes of hypoxia that over the course of the night is, causes incredible amount of inflammation. And if you get into the nitty gritty of it, you can go into like the radical oxidative species here, but really what it does to the vessels in your body is it's just chronic inflammation of these vessels, which results in hypertension, AFib, heart failure, stroke. And this is sort of irrefutable at this point. Like there is study after study that have shown that OSA dramatically contributes to these conditions, and that also treatment of OSA dramatically reduces the risk. Aside from that, like sleep is the best thing ever. Like sleep lets you think, it lets you interact with others. Fragmented sleep has been linked to like decreased mood. People who are prone to psychiatric disorders is much worse when they don't get good sleep. Productivity at work, ability to interact with your colleagues and your family is dramatically impacted by lack of sleep. So it's an important thing to consider. There's a book called Why We Sleep that if you're interested, highly recommend. And just sort of the etiology, it's multifactorial. The other thing I got was like, for us, we see a lot of skinny older white women who have OSA, who actually are the best responders to hypoglossal nerve stimulator. And that's because it's not just a disease of the obese, it's a disease of aging, it's a disease of anatomic deficiency. And so it's just, I think, important to keep in mind when you're thinking about OSA, is it's not just an obesity epidemic, it is something that many people struggle with, skinny people as well. So, sleep medicine and surgery. The first surgical procedure done for sleep apnea was tracheostomy. So this first documented was 1965 for hypoventilation. And I don't know if you can see this here, it's kind of small, but just this dramatic improvement in oxygen saturation during sleep. You go from like an 80% here saturation to 95% here. Just as like an aside, sleep apnea syndromes weren't really defined until the 1970s. And I think that's important because when we're thinking about medicine and surgery, often it's not until we start defining things that they end up getting treated. And so 1976, OSA is officially defined, and there's this whole spectrum of apneas from snoring, upper air resistance to true obstructive sleep apnea, and then obesity, hypoventilation. And then evolution of sleep medicine and surgery. We have the CPAP. So in 1980, there was a guy, Colin Sullivan, from Australia. He went to Canada where they were doing some procedures on dogs, looking at positive ventilation. And at this point, he was a physician. He had many patients who had sleep apnea who had trachs. And so when he came back to Australia, there was this trial that he was enrolling in, and one of his trach patients was like, well, what about that procedure that you saw in Canada for dogs? What it turned out is they took a vacuum, like just a normal vacuum machine, sort of reversed the rotor. And this was sort of the first CPAP in the 1980s. And CPAP, as you may know, like just provides positive pressure and opens up that airway during sleep. And this helped a lot of people because it went from, if you've got severe OSA and you truly cannot sleep at night, instead of getting a trach, you have this pretty effective option. However, CPAP has a lot of challenges, and at least in the US, it's cited that 50% of people are intolerant of CPAP, whether it's from discomfort, air leaks. There are a lot of nasal issues with it, dryness, congestion. 10% of people report claustrophobia and just rip it off during sleep. Some people report aerophagia, so they're swallowing a lot of the air during sleep. And it's also just inconvenient. Like if you're sleep apnea and you travel a lot, then you have to lug this machine with you. You have to make sure you've got sterile water. You have to constantly cleaning it. Patients that I've seen complain like, well, my partner doesn't like it, doesn't get it. I think that's changed a little bit now because CPAPs have become so advanced that they're much quieter now, but they're still quite cumbersome. And then the other thing I put up here is cost, because although insurance does cover this a lot in the United States, that's not the case in many other places in the world. So OSA is treated very well by CPAP. We can get people with severe OSA, AHI of 30s down to 5. That's a cure. But cure works if you're using it. And so even in the United States, we define compliance of CPAP as using 70% of nights with more than 4 hours per night. If you're sleeping 4 hours a night only, you're not getting much sleep. So average human sleeps 7, ideally 8 hours a night. So yes, it's effective, but effectiveness relies on adherence. And so that's where sort of sleep surgery comes in, because if you alter the anatomy, you don't have a choice whether you're using that CPAP or not. Your anatomy has changed. Like you're going to be compliant 100% of the time. So the nice thing about surgery is it's 100% compliance with the patients that go through it. And then I think we're all familiar with the UPPP. It was first published in 1981. And I think you've done a few here. We used to do a lot of them in Pittsburgh before sort of it came out, but it's a pretty brutal procedure. You come in, you take off both anterior postbiliary ribs, and then you take the uvula as well. And it has effectiveness, but I'll get into later, it's about only 41% effective. In the 1990s, the Stanford surgical protocol was developed. So this sort of looked at the UPPP, and then it looked at genioglottal advancement with hyoid myotomy. And so patients were separated into these sort of three categories. You get UPP, you get both UPP and GHM, or you get the GHM. And then, as you can see here, success rates 60% for combined procedures, 67% for genioglottal advancement alone, and then here they have 80% for UPPP. It's challenged much later. If those fail, as they do in a good portion of patients, the next step would sort of be an MMA, so taking the maxillomandibular and advancing forward, and that has almost 100% cure rate with OSA, but it's a very brutal procedure and a lot of like recovery time, morbidity, and it takes a long time. So does UPP work? It's pretty well accepted at this point, that not so much. So this is really based on this 1996 shared paper, massive paper. He looked at overall success rate and it's 41%, but even the success rate that he's listing is sorry, I'll go a little faster. Reduction 50% in AI, which here you get this AI 45 to 28. That's still severe or moderate sleep apnea. So it meets the criteria, but it's still moderate sleep apnea. And while it does help patients, they still have this heavy burden. So also with UPP, there's a high morbidity, a lot of side effects. People report taste change, globus sensation, dry mouth. The uvula is a huge lubricant of the mouth. VPI in France, like voice changes. The uvula is really important for some of the more like guttural tones that are used. And it's just not well tolerated. And these changes seem to be permanent. It's not something that just fades over time. So 40 to 60% of patients have these complications 5 years after. So just a brief overview of how sleep medicine and surgery is developed. The 1950s, sort of the first documented targeted surgery for sleep therapy, and then tracheostomy, like we talked about in 1981. In the 2000s, we get a little bit more towards the reconstructive side rather than the ablative completely with lateral pharyngoplasty. And then Pang and Woodson have really defined sleep palate surgery with expansion sphincter pharyngoplasty, which is found to be much more successful and much better tolerated than the UPP. And then in Italy right now, they're doing barbed repositioning pharyngoplasty. We haven't done this so much, but it is a quick procedure. It's easy. Essentially, you just take barbed suture and tack up the muscles as you would do in the expansion sphincter. So palate surgery, the ESP, first described in 2007, has an 83% success rate. You take the prophylaxis and then you tack it up to the hamulus here. So you do tonsillectomy, it's mucosal sparing tonsillectomy, so you can isolate the muscles and then tack it up. And this opens up the airway in the back. So it's just reduces lateral wall compliance and creates a larger space back there for breathing. And this is really well tolerated. Very little pain. Few patients complain of normal sensation, dysphagia, VPI. It's all much better tolerated. And so this is sort of a sign of the general shifts away from procedures like UPP, this ablative procedure, to more like reconstructive techniques. So what do we do? The patient comes into our sleep clinic, sees Dr. Seuss, our sleep attending. We do the same thing as sleep medicine surgery would do, because if you're getting a sleep surgery subspecialization, then you're also trained in sleep medicine. So the first thing we always do is weight loss, lifestyle changes. We do positional therapy, pillows. We try different types of CPAP masks, because no matter how good your surgery is, CPAP is a cure. It's just not well tolerated. So there are nasal CPAP masks that are better tolerated now, full face masks. We have a sleep administrative specialist who sits down with patients and literally tries these masks on with them. And then something that we didn't talk much here is the oral appliance therapy, which also can be very effective. It pulls the jaw forward, gets the tongue out of the way, but it can cause bite changes over time. And some people, again, just can't tolerate it for claustrophobia reasons. The procedures that we typically do, our most common ones end up being septoplasty and inferior turbinate reductions. One, because nasal obstruction is a big cause of sleep apnea, and also people who can't tolerate CPAP, sometimes because of nasal obstruction. This is very useful for them. Tonsillectomy and adenoidectomy, first line in pediatric patients with OSA, but also done pretty frequently in the adult population as well. Tonsillectomy, and then the palate reconstructive surgeries that we went through. And then sort of what's been more interesting now and what our practice has really turned to is for when people fail all of these measures, we go to the hypoglossal nerve stimulator, and the number one on the market right now is Inspire. So hypoglossal nerve stimulators. In 2014, the STAR trial was published. Dr. Ryan Seuss, again, one of our sleep attendings at Pittsburgh, he was one of the first to do this, and he was a big part of the STAR trial. So STAR trial was 126 participants. Almost all of them were men. Almost all of them were white, and almost all of them were upper class. This is something that was reflected on later. It's just an aside, like sleep apnea surgeries and treatment in the US, although I think that we have better coverage, is still sort of a surgery and treatment for the wealthy, which one of my co-residents going to sleep surgery, this is her passion. So she's trying to create a more, her drive is like to look at the inequity and find out ways to mitigate that. But FDA approval 2014, 2018, it's used pretty regularly, and now it's compatible with MRI. So the amount of Inspires in the US, especially in Pittsburgh, is really, really ramping up. And they work. There have been multiple publications and projects looking at this. They've got a very high success rate. This one here is from a 2018 study by Woodson. And in these AHI dropped from 30 to less than 20. And so this is really an effective way to decrease your cardiovascular risk, improve quality of life. And so every time they do this, they also do quality of life scores and Epworth sleepiness scales. And again, you just see people love this device. And even after 5 years, 75% of people are still using the device regularly, because it's not like CPAP. It's just just turn it on and then you're good to go. But it's not a magic procedure. We're still looking at long-term adherence rates. Expect to suffer just like CPAP and OT. People have devices, sometimes they stop using them. CPAP is still better curative. And the hypoglossal nerve stimulators, one of the downsides is you do, after about 10 years, that battery runs out. So you have to go in and get the battery replaced, which is a pretty quick procedure, but it is another surgical procedure that is, costly. So what we consider the hypoglossal nerve stimulator is just another tool in the toolbox for people who have failed all of their treatment. What's up next? So there are a couple different things on the horizon. There's a company called Nyxoah. Nyx, the OHI is their company name. This is a bilateral hypoglossal nerve stimulator that just sits right here. It's one incision, and it causes general tone throughout the night. And then ansa cervicalis stimulation, the sternothyroid muscle. If you stimulate it, you can increase the caudal pull, expanding the AP airway. And then cryotherapy pulse sculpting. So if you freeze off the tongue fat and the pharyngeal fat, there's also been some good work down in South America that's been pretty effective, and trials in the US are starting shortly. And there's OSA, very high prevalence, 10 to 30% here. 85% of patients in the US go undiagnosed, untreated. I'm sure that rates are similar, if not increased, here in South Africa, just because it's not something I think a lot of people consider. Like when people are tired, they don't really go, okay, I'm like tired because I'm sleeping, or is it just my job is stressful or emotions? But untreated OSA has a lot of morbidity associated with it. CPAP and OHA work, but are frequently not well tolerated. Sleep surgery, 100% adherence compliant, does work. And this is a really rapidly growing field within ENT. Every year we see more and more sleep surgery fellowship trained surgeons coming out. And I think it has a really big role in health equity. This is not a treatment just for the wealthy or elites. Like sleep affects every single part of our life. And if you're sleeping better, everything in your life, I think, functions more effectively. So that's thank you, everyone. This is my penultimate week. I'll be here until Wednesday next week, but it's been a really amazing experience. I thank all the registrars and fellows who sort of tolerate my ducklingness as I follow around. And thanks especially to Professor Shazia Peer, Prof. Johan Fagan for sort of starting this program this year. And then Louisa, I hope she's not here. I hope this is a picture of her because it's the only one I could find online that I think looks like her, and I think it was her LinkedIn, but. And then this is, Dr. Thomas Kappenberger. He's one of our sleep surgeons, in Pittsburgh, who, a lot of the presentation here is based on a lot of times that he's given to us as well.
Thank you. That's a great summary. Great. When I was in Pittsburgh, we still do UCT-Ps, and we're doing UCT-Ps with adenoidectomy, sometimes ending up with sclerosis.
Yeah.
And when Jonah Johnson has special interest in sleep work, they do one advancements and place advancements. Really feel very passionate about it.
Yeah.
The CPAP here, we buy a CPAP machine for about 20,000 grams. So yeah, so it's about 12,000 grams. So, yeah. But we want to get the smaller units. I'm the tiny CPAP. There's a tiny one I travel with.
Yeah.
Where it necessarily becomes very sophisticated. Without that, I'm not going to.
Yeah.
Yeah. And why do people with hypoglossal nerve simulators stop complying?
That's a great question.
We just switch it off.
They just switched off. Some of them just like, oh, we don't like to use it. We've had a few who can't tolerate the tongue motion. So it's usually what we try to do is if you have a patient who comes in and they've got a component of insomnia associated with their sleep apnea, they're less good candidates for the like Inspire, just because sometimes the movement of the tongue will keep them awake as well. Overall, though, I think rates of, at least from what I've seen in clinic, are pretty high. There have been only a few people of I think Dr. Seuss has now done 300 or 400 of these Inspires in the last 10 years. And I think he's only had to explant like 4 people because they just really disliked having it. One of those patients was a patient with fibromyalgia who thought that it worsened her fibromyalgia when she turned it on.
Okay. And I'm working concerned about the medical surgeries because it can impact on using CPAP touch.
Which one?
People who do palatal surgery and plastics.
Yeah.
And it can hinder use of CPAP subsequently.
I haven't seen that.
But because once you pull the palate forward when you get with confidence, you can't use it.
I don't know if that's
That's not true.
I don't know that that's true.
Okay.
Yeah.
I know that's the problem with UCT.
Yeah.
You can't use it, you can never CPAP.
No, I'll get back to you and double check, but I'm fairly certain.
Check it out, but you have to, the soft palate has to drop down to seal of the airway from the oral cavity, otherwise it will blow out the mouth.
Yeah, so, but I mean, I think that's one of the nice things with the modified, like the ESP and some of these lateral pharyngoplasties, is you still have a lot of integrity to the airway. It's just sort of tacking up the muscles. So even if you are applying positive pressure, and sometimes we do like a drug-induced sleep endoscopies on these patients after surgeries just to see what their airway looks like. And you still, I mean, you still get dynamic motion. It's just that the airway remains open. So I think it's not with like the UPPP where it's
right,
sort of one and done. I think that there's still a lot of.
You have to be able to seal the soft palate has to be able to seal the oral cavity.
Yes. Yeah.
Because otherwise, I guess you end up using a full face mask.
Yeah. And then full face mask is always the option. We've got some patients who prefer the full face mask even without.
Yes.
There's also, we have chin straps too, to keep the mouth closed. So people who prefer the nasal CPAP, but maybe just naturally they open their mouths. There are a lot of devices out there that will.
Yeah, thanks. It was a really nice presentation. Actually, I was very able to give us an update, talking about it in Monday theatre. I've heard a couple of talks on the hypoglossal nerve stimulator. One I'm still just not clear about is the actual practically how the stimulation works in terms of timing with the respiration and how you. I know it can also be titrated according to the PSG, right?
Yes.
Maybe if you can just elaborate more. Does an apnea trigger stimulation of the tongue, or is there a sign?
No, the device is on all night. So you set it for a certain time, say that your normal sleep latency is like 15-20 minutes. So when you turn it on, it's programmed to start 20 minutes after you follow, like 20 minutes after you turn it on, 20 minutes after you're set to go to bed. And then the sensor lead is in between the internal and external intercostal muscles. And what it does is every time you inspire, it sends a signal to the stimulator to activate. So and you see it when we do this operation, the Inspire techs are there with us. We have the machine on, and we make sure that that aligns well. So all night long, no matter like for the duration of sleep. One thing I will say, and one thing that we talk about is the sensor is not as accurate, I think, as we'd like. I think Inspire wants you to think that it is totally synced up, but I think there are a couple different studies that show that it's not. That being said, it's still the general tone that the muscles provided seems to be enough. That's why I think that these new sort of procedures like the NIXOA, the bilateral hypoglossal nerve stimulator, can be successful, because I'm not sure that the inspiration like clicking component is necessarily needed.
Sleep apnea the obstruction can be multi-level, multiple.
Yeah.
Now, how do you work up your patients
So
with sleep apnea?
for CPAP,
Well, overall.
For overall.
With history of sleep apnea.
yeah, so we usually, if they come in, if they've used CPAP before, we know they have OSA. If they're not using CPAP, we usually will get a home sleep study. It's really easy. It's just a prong. It's very small. I did it when I was in my sleep surgery rotation. It's very well tolerated. It's not bad. A couple nights of that, we look to see what their AHI, their overall sleep picture looks like. If for some reason they can't tolerate that, we take them in to do a PSG study. Then our first treatment is always CPAP, and for an insurance to cover any of these other procedures, you have to be sure to be non-compliant with CPAP. Okay. Or non-tolerant with CPAP, and that's sort of a soft.
But before we get to that, how do you sense the airway? How do you?
Yeah, so once they've trialed that, if they're like, okay, this isn't working for me, usually we'll take them in for a drug-induced sleep endoscopy. So drug-induced sleep endoscopy, it's a very, very quick procedure, 15 minutes. Use propofol to get them in a plane of sedation where the airway starts to collapse. You send your flexible scope in, and then there's something called the VOTE criteria, where you measure the levels of collapse throughout the airway. So there's the velum, there's the oral pharynx, there's the tongue-based collapse, and then there's epiglottis. And DICE is a really great procedure, not just for Inspire, but also like a lot of times we'll go in and we're like, this patient has circumferential collapse. And if somebody has circumferential collapse, they're not going to be a good Inspire candidate, because hypoglossal nerve stimulators just do AP, they do tongue-based forward, like anterior, posterior. But what doing the DICE allows us to do is it allows us to assess, are they going to be good candidates for like a extension sphincter pharyngoplasty? Are they going to be candidates for, you go in and they have a deviated septum, or if you're turbinate or like hypertrophy, then you're like, maybe that's the first step, and then maybe they'll tolerate their CPAP better. So that's sort of where DICE is. And then DICE is also required for insurance coverage of the Inspire.
Dynamic MRI, do you do that at all? Is that falls by the wayside?
Yeah, I don't think anybody's there.
Okay.
Yeah. In terms of imaging, we don't really get much other imaging on these patients.
Yep.
This is not needed. Most of it's like you visually see the collapse pattern.
And if they have nasal pathology, polyps, see if you sort that out first with you.
Yeah. Well, depending. If their CPAP is working for them and they don't need anything, then no. But if one of the first steps of their CPAP is working before you would jump to sort of palate surgery or hypoglossal nerve stimulator, then definitely like address any nasal obstruction.
So just to come off that, my understanding, and I don't know if it's changed subsequently, but the role of septoplasty and turbinoplasty, which is still, I think, partially due to the availability of CPAP in our context, but also it's often jumped to as the first line. But as far as I know, it hasn't been shown at all to make any significant change on the AHI, only in terms of tolerance of CPAP.
Yeah, that's correct.
So in other words, you guys obviously try and see that if there's poor compliance and it's on a nasal basis or grounds, then you would move to.
Yeah. Which has been shown to be effective.
Yes.
What do you do in Europe? Is even no snow?
It's
Some topic alcohol, please.
It's quite simple actually. So when some say they snow, we first send them to ESG. We do ESG all the time. We don't have at home sleep studies. And then when they come back, if there's a HI is higher than 15, we first start to see that
Yes.
first treatment. If they don't tolerate it or they have number lower than 15, we do the dice just to see what the options are. We do the bar position.
Yes.
Yeah. We also have happens in everything, maybe, but it's only reimbursed when we try all other. It's expensive.
How the bar work?
Yeah.
How does it work? How do you
How
do it?
does it- Yeah, so you suture like the arches, you suture them with barbed wire, and then you tie them up actually.
Why do you bar wire, not just man?
To keep it in place.
The barbs, it's just. It just pulls it,
It
pulls
pulls
it.
it, yeah, it's quite painful.
Yeah, people, we don't.
Yeah.
They do.
Any questions on the floor? You think it's. Yes. Yeah.
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 They give this stuff.
2 weeks, it's not big.
Really, and then it's
And
fine.
it's a quick
Then it's
procedure,
fine.
but like patients who.
Yeah.
No, it's no vision for patients.
Yeah.
You were very, very nice, it was great, yes.
Thank you guys, truly, this has been a really amazing experience, for me, and I've learned a ton, and it's been great working with everyone. Would love to see you guys in Pittsburgh, so I was like, if we
Are
should,
you done with this?
next Tuesday for last day, and then I fly back on
Sure.
Tuesday.
You climb all the mountains and you swim. Swim in both oceans.
So I'm in both oceans, very cold.
That's great, thank you very much, it was great to meet you.
Thank you guys, truly.
Did anyone ever look at those patients, the 40% that's successfully with the UCT and what their weight was prior to the procedure and after? I also wondered whether it's
So one of the interesting things,
very painful and they struggle to eat for a long time.
yeah, it's just way less. Ozempic is sort of an interesting new drug in like the sleep surgery world.
Yeah.
I actually think we're gonna be doing a lot more sleep surgeries because of Ozempic. Because people who don't meet BMI criteria for Inspire suddenly take Ozempic and now their BMI is appropriate for Inspire. It's a good time to invest in Inspire.